Great, good afternoon. Thanks everyone for joining us. Before I get into introducing our speakers for this afternoon, I just wanted to go over our agenda, and then at the end we will have time for Q&A. So this afternoon we are going to be discussing some of the precautions here at Penn Medicine that we've taken to keep patients safe, some of our surgical and outpatient volume trends, and what patients can expect from care at Penn Orthopaedics. And try to do this in a way that our two surgeon speakers here will answer some questions that we received from registrants in advance that will touch on some of the things around in-person appointments versus telemedicine, the experience for the patient and the surgeon during procedures and surgery. And then finally, we'll get to access and referrals, choosing between the in-person and the virtual appointments, and we'll leave time for a Q&A session for everyone. If there are questions throughout the presentation, please feel free to use the chat function anytime. We'll be keeping an eye on that. And if there are any issues with reception or the presentation, feel free to jot that in there. Rob also provided his contact information as well. So as we get started, just want to introduce Dr. Craig Israelite, who is on this presentation with me. He is the co-director of our knee service, the program director for our department, previously program director for the Department of Orthopedic Surgery, an associate professor, and certainly a great colleague of mine. So Dr. Israelite, thanks for joining us this afternoon.
My pleasure.
And we also have Dr. David Bazenka, who's our chief of hand surgery and the chief of orthopedic surgery at our Penn Presbyterian Medical Center, also associate professor of orthopedic surgery and a great colleague as well. So thanks for getting on here today, Dr. Bazenka.
Thanks, Kevin.
And I'll introduce myself, which is always a little bit awkward, but certainly easy to do. So I'm Senior Director of Service Line Operations, responsible for the Department of Orthopedic Surgery and the Musculoskeletal Rheumatology Service Line, which includes pain medicine, physical medicine, rehab, rheumatology, and we certainly partner with our physical therapy and radiology partners as well. So just to get right into a few things here that I'm going to take us through to get started, and then I promise it will be a little bit more interactive as we move along. Some of the things that we've done at Penn to make it safe for referring providers and for them to send to our patients to us has been a process throughout the entire COVID situation. And we've certainly taken steps to minimize the risk to our patients and our staff, and ensure that there's the appropriate supply of PPE, including gloves and face protection and gowns when necessary. We've taken steps to expand our visit lengths and allow for full cleaning in between patients. We've continued to support remote working opportunities to lessen the number of people coming in to our spaces to add to the volume of patients that are coming in. And we've certainly taken a slow ramp up process to be safe, to allow patients to get in and allow for there to be enough physical distancing for everyone that's coming into any of our sites. And we've done that in a stepwise fashion. We started after we were only seeing urgent and emergent patients on a regular basis throughout the intensity of the height of COVID. We started to ramp back up and bring in 25 to 50% of our patient population. And then as we got a little bit further into late May and into June, we got close to 75%. And we're very happy to report that we continue to do it in a safe manner. We're getting closer to that 100% of pre-COVID volume. And when we say pre-COVID volume, I'm going to share some stats with you a little bit later that will show you that it isn't necessarily all in person. Right now we have about an 80-20 mix. We're as high as 80% in-person visits and 20% virtual. And we expect that to remain that way, hovering right around that 20% virtual for some time, as we encourage folks to take advantage of that platform for safety and really to reduce inconvenience to any patients as well. It's a nice opportunity to have patients avoid having to come into the city and park or take mass transit if they can take advantage of some of our virtual opportunities. So we're also continuing to utilize our staff to reach out to patients in advance and do as much of the prep work as possible. And we here at Penn have a platform called My Penn Medicine, which provides e-check-in and copay collection, as well as a variety of other functions to make virtual opportunities to get in touch with us easier and easier for our patients. And certainly we are communicating with everyone before they come into the building via phone calls, texts, and we have something called the switchboard, where we can communicate with patients and let them know things that we want them to do in advance of their visit, things that they might need to know when they arrive, and also having the ability to communicate with them to time up their entry into the building to avoid as much of the waiting room as possible. And so we've done this with a staggered in-person visit rollout as we've gotten more into our in-person capacity. And so we've staggered schedules so that many of our providers are not seeing multiple patient loads in one area of an office space. We've installed all the necessary precautions around plexiglass barriers. We've utilized signage and tape to create visual cues for 6-foot distancing. And we've certainly taken opportunities to communicate with patients via the phone and/or text to let them know whether they are going to have a little bit of a wait and they want to perhaps wait in their car for sites where we have on-site parking, or for those who want to wait, privately outdoors, we have that opportunity for them as well. But right now we're finding that we're able to get patients in at a rhythm that doesn't allow much room for waiting, and so we're quite happy with the rhythm of each of the days in our clinics. We've also taken the steps to remove magazines, collateral, things that would be touched by multiple people in any one space, our tablets, et cetera. And we're doing all this because we want everyone to feel safe. We want our patients coming in, and as you're referring patients to us, we want you to feel secure in not only our outstanding care, but our ability to provide that care during a COVID environment. So this is some photos here on this slide that show you one of our waiting rooms. And so we've taken the steps to reduce the number of seats in any one space and allow for that 6-foot physical distancing. And you'll see this at all 15 of our sites throughout the region, that we've taken steps to make sure that patients know that they really do need to practice physical distancing. It's not an option. And we go through the waiting rooms regularly and check in, and we really see that not as many people need to sit in the waiting room the way that we've been able to set up the cadence of our daily templates. And so this is a great slide that we developed internally here as we were planning to receive patients back into our physical offices. And so in this upper portion here in light blue, you'll see our pre-COVID workflow. So pretty much our day-to-day right up until COVID became something that we needed to screen for. And certainly before we took the drastic measures to slow down our volume and then to slowly ramp up, we were doing our COVID screenings in person. Folks would present at the front desk. They would be screened based on a set of questions that have changed multiple times throughout the last 4 or 5 months. And then if they passed that layer of screening, we would check them in person. We would collect their copay physically. We thought nothing of collecting cash or a credit card from patients. We would have them sign any of their consents, HIPAA, general consents for the health system. We, of course, would send them over for any imaging or x-ray as appropriate for their visit, and did that in person. We'd have them sit in the waiting room if there was not an exam room available for them at the time that they arrived into our suite. And then we would bring them back into the exam room. They would participate in some nurse triage, all done in person, height, weight, vitals, all the usual things, close contact in an exam room. They would have their exam by their physician or their physician extender, and then they would have checkout or surgical scheduling in person in an office, one-on-one. And this was our normal day-to-day flow, probably not unlike what anyone else experiences in many physician offices and practices throughout the region. As we went into a COVID environment, now that we're in a post or living with COVID environment, I should say, We're doing those things that are now in dark blue. We're doing as much of that virtually or ahead of time as possible. And that's really to limit the amount of time that our patients have to spend in the clinic spaces, to limit any exposure if someone is asymptomatic or didn't trigger any of the screening questions for COVID, and really to reduce that time spent on any one-on-one basis throughout our office. Get the patients in, provide them great care, and then do as much of this virtually as possible. So we really began doing the COVID screening via phone and or text. We did it with them when we spoke to them to confirm their visit. We started doing things through Penn, as I mentioned earlier, our electronic platform for managing and participating in your own care. We started to do what we call a pre-check-in or an e-check-in via Penn for patients that don't participate in Penn. We would call them personally and do that in advance of the visit. We began collecting copays via Penn. We also began collecting copays over the phone. And so, that was another opportunity for us to limit that physical interaction. Consents were done virtually, and unfortunately, no one's come up with a way to do X-ray or imaging virtually. So we did have to do that in person. And so that was one of our touch points. And then you'll see here that the waiting room is crossed out because during especially in the early days of our resurgence post or living with COVID, we cut out the waiting room completely. We really tried to set it up so that patients could be staggered enough that they would come into the practices if they had to have limited interaction with the front desk, just to announce their arrival, get anything done that wasn't done in advance of the visit, do a quick triage with the nurses, things that you can't do over the phone or virtually, such as weight or vitals, and bring them right into an exam room. And then when we would bring them into the exam room, we really limited the number of personnel. We're fortunate to be part of an academic medical center and system. One of the key missions for us is education and training. We value and really enjoy our residents and fellows. But the idea of having a physician, a patient, a resident, a fellow, a physician assistant, a nurse, maybe in pre-COVID days, a family member or two in the office. That was not an ideal scenario to keep everyone safe. And so we began having physicians and or advanced practitioners really cross cover for one another and be as independent as possible to give them their exam. And then checkout was really done virtually. If you needed to schedule surgery, many times our patient care coordinators would set up a video visit with the patients, sit down with them, look them face to face, and go through their surgical journey and packets with them. And so we're able to do a lot of that virtually as well. So this is something that we still reference now as we're always looking to do this in a safe way to get patients in. We have a responsibility to care for them and provide as much time as possible for them in the office that's appropriate. But as we all have learned, spending close contact with anyone who perhaps is asymptomatic and didn't know they were positive, didn't trigger the questionnaire, spending 10 minutes or more in a closed environment with them is a little bit more of a moderate to high risk. And so we wanted to eliminate that as much as possible. And so just some common questions, from my end that we get, and some of this was also asked in advance around, how are we handling in-office visits? And so the number one question we get, and I know that Dr. Israelite can back me up here for sure, I'm sure Dr. Bazenka as well, is around the visitor policy. And certainly it is difficult for anyone coming in to receive care to not bring a friend or a family member or an advocate with them. And we realize that the best case scenario is when you bring someone with you, because they often catch things that you're not able to catch while you're overwhelmed sometimes with the news of needing surgery or conservative treatments or physical therapy or whatever it may be, that can often just be, stop you dead in your tracks. And so we think about that for patients, and we know that's a difficult situation, but limiting the number of people in the spaces at our ambulatory sites is crucial. We do make case-by-case exceptions, and certainly for folks that have concerns or issues around cognitive function or any type of disability, anyone who needs someone there for their care plan. And so we do make exceptions. So they are screened appropriately, just like the patients themselves in our outpatient offices. For our surgical patients, visitors are limited to one person, and we have a designated waiting area. But we do find that our patients want to have a loved one physically on site with them, even if their surgery is same day and they're going to be leaving with that person. We do have a waiting area for them, so that doesn't need to be a barrier for our patients coming in to see us. Another question that we get is around eye protection. So everyone's now, masking. We have certainly seen great adoption of the masking policy, and we have seen tremendous work around the eye protection. So within the last several months, not immediately when COVID began, but after we had been dealing with it for a bit, we came up with an eye protection policy. So you'll see, or your patients will see, eye protection being utilized when they're in close proximity. Not everyone needs to wear eye protection, but folks that are coming within, close contact with patients in an exam room. So think of the physicians, the nurses, the advanced practitioners are wearing eye protection. It's disinfected in between each use. So I know that makes people feel a lot more secure. We do clean the exam rooms regularly in general, but during COVID, we certainly allow enough time for a proper turnover. In orthopedics, we don't tend to see a lot of infectious diseases or things that are spread via contact as much, but certainly we take that very seriously regularly. And during COVID, we've done a great job of turning those rooms over. We also get a lot of questions around handling of a COVID positive patient when they present to the building. We'll talk a little bit more about what that's like in the surgical arena, but when they present to the building, they either were screened and didn't have symptoms or didn't trigger at that point, or they weren't screened for some reason. We do temperature screening when they arrive at the building. And if they present and they either self-identify as being COVID positive, have a high temperature, have symptoms or some other exposure, we have a protocol here to make sure that they can get into the building safely without exposing others. We make sure that we are wearing masks and eye protection. We escort them directly to a room so that they're isolated. And then we figure out from there how we're going to provide care for them. We can't just say because you're COVID positive that we can't provide care for you. We can do it in a safe way with appropriate PPE, and we can do it with appropriate isolation. And so we haven't had many instances, if any, that I can think of where we've had that occur in our outpatient offices, but certainly it has here and there, and we have a process for it. And then masking seems to be a very big topic recently in the media, and certainly we encounter some issues around it. And so, we'll treat your patients with kindness and help educate them around the mandate to wear the face coverings. But we do have exceptions for children, certain medical conditions, and we'll work with folks to make sure that they can get care without running into any issues. So one of the key areas, I'm sure, for referring physicians and providers is, how are we providing surgical services in a safe way? And certainly we wanted to be sure that our staff was safe, our surgeons were safe, but our patients as well. And so we do preoperative COVID testing within 72 hours of the surgery, and it's done at multiple sites throughout the region. So if you have patients that are coming from Princeton, from Lancaster General, the Lancaster region, from the western suburbs, other parts of New Jersey, Cherry Hill, and in the city, it is likely that we have a site that is fairly convenient for you to go and get COVID testing done for your preoperative needs. We also take serious precautions around cohorting patients away from COVID units. And this is great to be able to speak to your patients around, well, should I wait to have surgery or should I, get my relief now? And they should not be concerned about contracting COVID. We're taking every precaution. Certainly the risk is no greater than other day-to-day activities that are required. So we're very proud of the Penn system for doing this in a safe manner. And then for COVID positive patients who need surgery, we can't turn our backs on those patients. We still need to provide care if it's urgent. And so if it's urgent or emergent, we'll use proper protective equipment and isolation. If it's not urgent and it can be delayed 28 days or more, then we certainly, at that point, we will proceed after without further testing needed. At that point, they wouldn't need a preoperative test due to, having already had the infection. And then if it's not urgent, but it can't wait the full 28 days, we'll delay 10 days if there are no symptoms present, and then we'll retest. And if it's negative, we'll have them proceed. If there are symptoms, we'll delay and retest only when they're symptom free for 3 days. And if negative, proceed, and if positive, delay. But ultimately, this is a little bit cumbersome to follow. We take it case by case, go literally down a flow chart, say, this is where you're at in the journey here, and these are the steps we need you to take, and guide them through that. But ultimately, we are always going to do what's right for the patient and right for other patients to limit exposure. So I just want to share with you some statistics around what we've done since COVID really came into our lives in a significant way. I remember very keenly that Friday the 13th, I was in my office till about 9 o'clock at night, managing some of the organized chaos around COVID and how it was evolving. And so I always remember that Friday the 13th of March, I don't think I'll ever forget it, where I was and what I was doing. And I remember the week of the 16th, and as you can see on here with some of our stats, we came down from that gray bar up there of roughly 2,400 visits per week to just several hundred, and that decreased even further as we were able to take care of some of our post-operative patients and patients that just couldn't wait to see us as we got into the week of the 23rd. And then as we got our legs under us, we started to be able to see a lot of patients virtually. And so you'll see that blue bar there that starts to really grow from the 23rd forward is our virtual practice. So we converted many patients that still needed to be seen, and not just established patients, but ultimately, as we got closer to the week of the 13th of April, new patients who needed to know what they should do to manage their pain or manage an injury. And we were able to have that virtual opportunity for them. So we went from having almost a non-existent virtual practice to seeing 5, 6, 7, 800 virtual visits per week in a relatively quick time frame. The good news around this data here is that I look at the week of the 15th because that's the data that with things that have, our billing has some lag. We've had a little bit of a holiday blip for, rightfully so, for Memorial Day. And then, of course, for this past week for Independence Day. But if you look at the week of the 15th, that's really a banner week where we were able to see over 2,100 patients and a much larger in-person volume at that point. And so this is certainly very exciting for all of us. And this is exciting for all of you to be able to refer patients in. Then a little bit more around statistics, just to give you a sense of where we were. So, again, looking back to one of our lower weeks on the week of the 27th, we did 41 surgical cases, and we're usually hovering right under that 250 cases per week. So that was a tremendous change for us. And a lot of that was actually trauma cases that just couldn't wait. But fortunately, when we got the all clear from the state and from our health system, we put into place a scoring system to make sure that we were taking care of patients that were appropriate and needed care, but were also appropriate to come into the health system during our COVID environment. And we started the week of the 4th doing more cases. We got to 164, which was really miraculous to go from 41 to 164 in such a short time frame. And we got as high as the week of the 15th again, 243 cases. And this data is a little bit old. It will grow as things come through the billing system, as I've said. But certainly, this is a great trend in the right direction. And so I'm going to stop sharing my screen just for this portion of the discussion, and I'm going to start interacting. I have some questions that came in for Doctors Israelite and Bizenka that I want to ask them and have them share their experience with you, and really talk about the experience of they themselves as surgeons, but also as our patients as well. So the first topic is going to be around telemedicine lessons learned. And so, for both of you, and I'll let Dr. Israelite go first here since he's on my screen at the moment. What would you say are the types of appointments that are most appropriate for virtual medicine so far? How do you see that working out so far? But also, how do you see it in the future?
Well, first, that was great summary and presentation. And one of the benefits, true benefits of being at the university here is we're surrounded by people such as Calvin Jordan and others who have prepared in this very difficult situation. I mean, this has been difficult socially, medically, financially for everybody. And so the people have been able to navigate us through this safely. If we were able to be in the same room, I'd give you a round of applause, but not just you, but others. And it really is a great team. So because of that in those numbers, the telemedicine, the lessons learned so far is the biggest lesson is that we can do it. The technology is there. We can appropriately screen patients. It's just been I'm an stick in the mud, kind of never change person, but I have to tell you that I've adopted into my practice. And it really helps me and the patients decide what their diagnosis is. Do they actually go somewhere else, or do they need to come in? So that's been the most impressive thing to me, is that we've learned that we can use it, and it actually is quite helpful. The only discerning thing is it's not for intervention. That's what people have to understand. So I can't give someone a shot or aspirate a knee over the telemedicine, but most medical diagnoses are made through interaction and listening to the patients, and the ability to see their x-rays has helped us tremendously. So the biggest lesson, we can do it, and I think patients are overwhelmingly satisfied with the telemedicine, so much so that it kind of hurts my feelings because there's no waiting in the waiting room, and many of them at the end will say, do I ever have to come in? It's actually been very funny. I'll let Dr. Bizenka add to that if he would like.
Great, thanks, Greg. I would agree. Calvin, we would thank you and applaud you and the rest of the administrative staff here that's kept us safe, have developed our process in a safe manner, slowly opening up to make sure that everyone will get an optimal experience. And I think one of the benefits of having this whole COVID process is that it brought along this telemedicine as quickly as it did. So the question was, what type of patients do I like to, or do I think are most amenable for telemedicine? Well, new patients, return patients, and postoperative patients, they're all a component that are amenable to telemedicine. New patients, particularly, haven't had a prior assessment. They haven't had a prior workup. As Craig said, 90% of the time, we know the diagnosis just talking to the patient, and we use the physical exam in order to confirm the diagnosis. So, for example, I see a patient with numbness in their hand. It could be related to their neck, their shoulder, their elbow, or the wrist. It can help confirm that they're going to see the appropriate service, have the appropriate workup before coming into the office. I see patients that are return patients that I just need to check the range of motion. Bend your fingers, straighten your fingers, see how well they're moving, assess whether they're wearing their splint appropriately, and check their x-ray, make sure their fracture's healing appropriate. And those visits are very amenable to telemedicine because the patient can do this at home. They can do it in their car. They can do it at work. And so those are the issues that I think are helped most through telemedicine now.
Yes, certainly. Thank you for that. Those for your kind words. We have a great team here, and thanks for explaining that for us. One of the questions, and I'll ask you, Dr. Bizenka, here on this one, is, do you prefer a telemedicine appointment before even seeing a patient in the office? is that a great way, as you were saying, you can triage and vet a lot of what's going on. Is that something that referring physicians should encourage their patients to take advantage of? Or really it's just, up to the patient?
Yeah, it's truly the patient's preference. It's funny, there are some patients say, oh, I want an in-office patient visit face-to-face. And some of the elderly patients initially are reticent to going through the tech, can't think of the technology to be too complicated, but once they do it once, they realize how straightforward the process is now. We have my administrative assistant check with the patient, make sure they're online, make sure they go through the switchboard process, which is very easy to set up. And I think it makes their face-to-face appointment, when it does come to that, very efficient. I have already discussed whether the patient needs an injection, or would they just want to do a splint or have surgery. And so they're able to read the literature, go through the process beforehand. During their telemedicine visit, I can bring up different diagrams and review that with the patient. I put it in their patient instructions in their portal so they can look at that later, review that so that when they come in, I know that they want an injection. That's set up. The patient can expedite their visit by going through that telemedicine visit. So my personal preference, I think it makes it much more efficient having a telemedicine visit. But again, it's patient preference.
Great. Yeah, I appreciate that. Thank you. Dr. Rizzoli, do you have anything to comment on that from your end before I go to the next question, which will be for you as well?
I agree that it depends on the patient's experience, if they feel technologically savvy. Some people want to come in or do need to come in, but it's a great screening tool, and it is efficient. And particularly because we're at Penn, we see people from Scranton, from Dover, Delaware. I can't tell you how many times people drive 3 hours to see me, and I say, oh, it's not your hip, it's your back, where many times I could figure that out just by a telemedicine visit. So I agree with Dr. saying it's a very great screening tool. People who mostly see me, though, already have a known diagnosis, have failed treatment. That's a little bit different. I do believe that I like to talk to them in the office, and I draw pictures and show models about how we do things. That is a little bit more different, but that again, it's a different phase. Those are patients who know really what their treatment is going to be. But as a screening tool to discern where they need to go, I think telemedicine has been wonderful.
Great, thank you for those comments. Another question: should referring providers order all the imaging that they think they might need or that you might need for the patient in advance? And I'll say this, that we've spent a lot of time developing the image sharing here at Penn, and one of the great benefits of having our patients go to a Penn radiology site is that it's automatically into our record, and it's very easy for you to see and to share with the patients. But we also have opportunities for patients that don't go to a Penn radiology site to still share their images with you and the care team, whether it be virtual or in person. So do you like to see those referring docs order that imaging, or is that something you prefer to do yourself?
Well, again, so my practice is a little bit different than Dr. Basenka's, so a total joint surgeon versus hand surgeon. And so I do need to see an x-ray at some point. When they come to the office, it's very easy. We just have them get an x-ray here. As far as the referring physicians ordering them, x-rays are really all they need. And they should have an x-ray, and they can get an x-ray. If it's in the Penn system, it makes it very easy because I can absolutely see it. Otherwise, we do have these sharing mechanisms, which I can upload and see their x-ray. So having to come in for an x-ray is no longer a sticking point. I can see x-rays from almost any radiology department that there is. So I do prefer to have an x-ray before I see the patient. So the primary care physician can order it, in which case we can see it, or we can order it and they can go get it locally as well. But before I see them on the first visit, in my specialty, I need to see x-rays. Regarding MRIs, that's different. I would prefer them not to order MRIs and more or invasive tests because it's expensive. And we actually published a paper here to show the non-utility of MRIs in patients over age 60. And so start with an x-ray. And so I would prefer either they order the x-ray or they can call us, and part of our screening tests, my staff goes through and say, listen, you need an x-ray. They send them an x-ray request, and they can still get that locally, and I'm still able to see it. So that's worked out very well.
Yeah, that's terrific. And Dr. Brzenka, a comment on, from a hand surgeon perspective, for you, is that radiology, that imaging, are you along the same lines, or do you have a preference in a different direction?
I would agree. Particularly if patients have a traumatic event, we need x-rays. And the vast majority of patients that come in with a trauma or some type of injury, we're getting a film. If they have a trigger finger or an overuse phenomenon, it's rare that they get an x-ray. And then even EMGs, I'll wait to make sure a patient has been treated for a period of time before I get their electrodiagnostic studies. And in similar fashion, the MRIs, I would rather see the patient first, make sure they need an MRI or further diagnostic testing, but the x-ray certainly is very appropriate prior to the visit.
Terrific. Thanks for that. So the next section here that I wanted to talk about with you and have you share your experience, and Dr. Brzenka, I'll start with you. Perhaps you could talk us through a story, patient story, de-identified, of course, who came in through, perhaps virtual medicine or came in during the COVID pandemic and received surgery at one of our surgical centers. Perhaps one of your outpatients that have come in, and what that was like, what was unique about it, perhaps any of interesting diagnoses that you found that maybe they had waited, something else would have come about for them. So please, let's share a story.
Well, first, I would agree with Dr. Israelite that my practice is very different from his. All he needs to know is the right knee or left knee, and I do so many different things. No.
Okay.
So one of the problems that we have are patients that have certain injuries or lacerations to their hand. They're told they have a tendon injury, and quite often it's not. It's just a skin laceration or something that can wait. If you do have a tendon injury, you'd like to be seen very soon. Within a week or two, we'd like to repair tendons. And so we did have a patient during the COVID time that had an injury, called in, it was late in the afternoon. I was able to do a telemedicine visit, and just by looking at their hand, you could see that they had lost the resting cascade of their hand in the digit that had the laceration. So normally your hand is in a curved position at rest. Well, if you cut the flexor tendons, the one digit is going to be lying in an extended position. So just looking at the hand is all I really needed in order to make the diagnosis. We were able to expeditiously schedule him for surgery, went through the procedure in the short procedure unit here. The tendon was cut, we repaired it, he went off to therapy. He did see the therapist in the office to get the splint made and start the exercise program, and is able to do telehealth through our therapy unit as well. And the therapist had called me and said, I think he may have ruptured his tendon. And that's, again, an urgent process. Fortunately, I was able to do another telehealth visit, was able to assess his hand. He took his thing out of the splint and saw that he had the normal resting cascade of his digits, and was able to confirm that, no, he had not ruptured his tendon, and saved him a visit of running back down to Center City or out to Radnor office in order to see me, and was able to continue his therapy protocol. And so I think that's where the telemedicine was very helpful for us to be able to expedite this patient's care.
That's great. Dr. Israelite, I'll ask you, since your practices are different, and that's why we chose you to join us today, specifically around a story that you could share in the hospital setting, perhaps one of your patients who had to spend the night or was discharged same day, and give us your perspective.
Well, first of all, I did identify if it was the right or the left knee. Thank you, Dr. Brzenka, for that. Yeah, so I'll talk more about, so there's lots of patients, but a lot of the discussion now is about safety and inpatient hospitalizations. And so, I would tell you that I think it's safer to be in a hospital these days, particularly our hospital, than to go into the grocery store. I feel, because everyone's following all the protocols. But it is a concern of every patient, as well as every provider in this institution, from dietary, through the secretaries, through the physicians. And so I had a patient who was one of the most educated people here in the university. He's an emergency room physician who knows more about COVID than any of the talking heads on the news, who opted to have his elective total knee replacement several weeks ago during this, pandemic. And, he did the research and really delved into it, and he had a very successful total knee. And he had his other knee the year prior. So he was able to compare the differences, and he felt very comfortable, particularly with just the way he was handled and the cleanliness and attention to detail that we should all be doing forever. But quite frankly, the one of the good things that has come out from a very terrible virus is that we've learned to be better caregivers and respect privacy and distancing. And so he came in, had his knee, went home the next morning, and wrote a wonderful letter how everyone was professional, and he felt extraordinarily comfortable with the entire process. And so I think if someone who is, and not just a physician, but someone who's in the emergency room on the front lines of this feels comfortable, then I think that other patients can take some solace in that.
That's terrific. Thanks to both of you for sharing those stories. I know there are many more stories that we could speak to, and certainly it's been a moment of pride for me to watch many of our team members rise to the occasion and do a really terrific job. And I agree with you. I feel very safe going into work every day without any issue. Next question, and Dr. Zero, I'll open this up to you first, is you had mentioned a little bit earlier, but we really saw our physical therapy partners, especially Penn Physical Therapy and others, they utilized a virtual strategy for physical therapy and some in-home services beyond physical therapy as well that really found their rhythm during the COVID crisis to give patients the comfort and security and confidence to go home and still get the benefits of those services. And so can you share a little bit of your perspective on that and how that's been going for your patients that are recovering at this point?
Right. Well, just briefly, because this is a whole topic in and of itself, and we're going to run out of time. So total joints, I believe that everybody does need post-operative therapy. And particularly now where people are either same day or go home the next day, this is in the home setting. And so many people get home therapy visits by our visiting therapists who, again, are well-trained. It's a very safe, it has to be safe for them as well as for the patient. And so they will come out to the home. But the thing that has sprung up even more so is these virtual physical therapy visits where you can, just like if you're watching on the computer, do your therapy. We have several programs going on here. We have a very large research program going on right now with something called My Mobility, where you use your phone and it tells you what to do, how much to do every day. And so I think that this is the new norm, quite frankly, because going back and forth 3 or 4 times a week to a physical therapist is time consuming, it's costly, many people have co-pays. And so we can give physical therapy in a home environment, and we track our results very carefully here because we're very outcomes based. And I can tell you we've been back doing this now 6 weeks or more, and we have not seen any adverse problems to date, regarding postoperative complications or diminished rehabilitation with these new protocols. So I'm very pleased about it, and it is, again, one of those new normal things which I've come to accept.
Perfect. And Dr. Bazanke, you have some, thank you very much for that, Dr. Zero, but Dr. Bazanke, you have some specialized hand therapy that's, really one of the hallmarks of our program and the ability to provide patients with, an exceptional post-operative recovery period. Any comments around, hand therapy opportunities and the specialization around that being done virtual as well?
Yeah, in hand surgery in particular, the result is a significant portion is dependent on the appropriate therapy that's performed. We have a group of therapists that are with us in the office that we run our basic protocols for each diagnosis. That way we can coordinate and have direct communication with the therapist at the time of the visit. And it's helpful with the telemedicine that can be assessed regularly without having to come into the office, just as Dr. Israelite said. And so it's just as amenable to hand surgery.
Perfect. Yeah, thank you. Thank you for that insight. So just as a reminder, anyone on the line that has a question, feel free to put it in the Q&A or in the chat box. I did see a Q&A come through, and Dr. Israelite, someone here asked if the information around the paper around the effectiveness of MRI after age 60, I think that you were mentioning a little bit ago, if that could be shared broadly with the attendees.
Yeah, I guess I can type and walk and type and talk at the same time. I can type it in, but it actually, so I was the senior author on it. It's under Khoury, Khoury et al. In orthopedics about 8 years ago. I forget the exact volume, but if you do a search line with her or my name, it'll come up. And the title of the paper is the efficiency or efficacy of MRI in patients over the age of 60. And the study showed that it was very non-efficacious. But you'll be able to find it. But I'll type it in a second, but you could just look on it on Medline and find that easily.
Terrific. Appreciate that. Let's see if there are any other questions. Give everybody just a moment in case there are any. Although we did receive some questions in advance, so it's okay if we end up not having as many as we would have expected. So I'll just ask one additional question while I give folks a chance. It's my last question from me. For the both of you, do you see this? We talked about its efficiency around teeing people up for their in-person visit or whatever their next steps are. Maybe for some of your junior partners who are building their practices, do you see it as an opportunity to increase access for patients and give some flexibility? Our patients are starting to expect, similar to the banking industry. If you look at the banking industry 15 or 20 years ago, they were open Monday through Friday. The inside was open 9 to 3, and the drive-through was open maybe until 5 or 6 o'clock at night. Saturday eventually came along, for 3 hours, and that was it. And especially for those of you who know our region, Commerce Bank many years ago came along and opened 7 days a week. And opened on payroll day until 8 o'clock at night. And so they realized that their customer, which our patients are our customers in a lot of ways, needed to be seen when it was best for them so that they could work and provide for their families. Do you see this as an opportunity to increase that access and provide that balance for our patients and perhaps for your junior partners more so than you who have established practices and referral paths? Do either one of you have any comments around that?
I would say that telemedicine is here to stay. That's a definite. And like you said, it definitely increases the access. We also have other things like My Penn Medicine. So it's not just the telemedicine visits. The communication skills here at Penn have been really developed very well. But I just want to get this in as well, along with that, is that it's not just the patients. A lot of times families, particularly I deal with elderly patients, they want their significant other for kids. I did a telemedicine visit the other day with 10 people were there in the room, but they could never get everybody together to come downtown. I've had patients who their significant other has dementia and they're afraid to leave them. Someone with a special needs child who it's a hassle to come down for a visit. So I could talk for 30 minutes of all the stories over the last 4 to 6 weeks of how this has helped, but you want it to help without deterioration or less of an effective solution. And I haven't seen it. You just have to remember that for procedures, you do have to come to the office. So we're not going to go away. We still have to be here, but it just gives you an avenue to do all these other options. And people are afraid to use it, but it's here, and it's going to become a greater part of our practices as we move forward.
Perfect. Dr. Buzenko, I'll open it up for you. Just some commentary.
Yeah, I will agree. I think there'll always be an element of telemedicine within my practice and others within the hand service. It is helpful for the new patients, as we said, follow-up patients and patients that live at a distance. It's here to stay. I think there are so many benefits as we've expounded previously.
Terrific. So we've given some time to put in some Q&A. Dr. Israelite, thank you for putting in the the journal information there. We're not seeing any other questions, so I'll just take a moment and thank our referring providers and our partners out in the community for taking the time to join this webinar. I'll thank you for your trust in us as a care provider. We certainly appreciate that. I want to thank Dr. Israelite and Dr. Bazenka for joining me on this panel and being great partners as always. This is recorded. This will be available for distribution. And before we go, I'll just do one quick check for an additional question. Oh, we did get one. The question is, have you had success convincing a patient to be seen in person or via telemedicine? If, as a primary care provider, I know I have a patient who should be seen, but they're not amenable, is a call from your office helpful in explaining the need? That's a great question. Dr. Bazenka, since you're live on my screen first, or Dr. Israelite, do you want to comment on that?
I think that a call from the office, and particularly, human touch is the best, but there's no question that seeing a patient during a virtual visit is much better than just the call. So if we can do a virtual visit, that's optimal if they can't be seen in the office, but certainly just a call just to discuss with them how simple the process is will work as well.
And I would just like to say that we don't try and tell patients what to do. They have to feel comfortable, and if they want to come into the office, then we're going to make every available option open to them. If they want to do telemedicine, we'll do telemedicine. So I wouldn't use the word convince. I don't really try to convince people which is better. The patients know what's best for their particular situation.
Yeah, it's terrific. That's a very supportive response for our primary care referring providers. And so thank you for the question. I'm not seeing any other questions here in our chat box. Dr. Bazenka or Dr. Israelite, anything to end?
Yeah, but before you go about office, so I still have patients who are emailing me directly saying, "Are you seeing patients?" So the answer is yes. We're not at full tilt because of some of the requirements of distancing of patients and keeping the pods free and clear of too many people. But I think we're honing in, and the wait times for inpatient visits is not that long at this point because we are doing more telemedicine visits. So I would just say to your patients that, yeah, we are open for business, so to speak, that they are certainly, we're certainly here to provide care.
I would agree. We're very fortunate to have the telemedicine. We're very fortunate to have a safe environment here in the office as well as in the operating room to continue to provide care in this setting.
Perfect. Well, thank you both for everything that you're doing for our patients. Incredibly proud to be a part of Penn Medicine. We're very fortunate for our referring partners. We're very fortunate to maintain our staff, and we're quite proud of that. We are here. We're going to provide everyone the same great service and experience, no matter what challenges we face over the coming year. And again, I'll thank everyone for joining and end here. Stay safe.